Thank you. So I'm Fiona Lalloo. I'm a consultant in cancer genetics based in Manchester. I've been doing it for a very long time. And I've been given the brief of an introduction to Lynch syndrome. I'm sort of assuming that most people know what Lynch syndrome is, but I'll go through it. If there's anything during the talk, just interrupt me. As I said, we'll have time for questions afterwards. So this was a family I saw 20 odd years ago now, and we were originally asked to see this woman, and she'd come to see us because her sister had been diagnosed with ovarian cancer, and she was anxious about that. Talked to her about the family history, and the concern was that on the father's side of the family, she had a paternal aunt who had been diagnosed with breast cancer at a young age. So the one thing you start to think about is, well, this is one of the breast cancer predisposing genes because they can cause both breast and ovarian cancer. And there was this vague family history on her mum's side. Mum had cancer of the cervix and had died from that. So I said to her, well, actually, there are different types of ovarian cancer. Let's try and get some information about that. And if you can get consent from your sister, we can get hold of her histology. And actually, whilst you're at it, see if you can get any more information about your mum's side. See if you can get some death certificates or any information from the rest of the family. We got the histology on the sister, and she had a mucinous ovarian cancer. And that's really quite important because you don't see mucinous ovarian cancers associated with breast cancer. So that immediately meant that I wasn't concerned about the paternal aunt. And then she came back with some death certificates. And her mum had had endometrial cancer, as had her grandmother, and the great aunt had had cancer of the cecum, so a bowel cancer. So this had gone from a woman who was anxious about having a breast cancer predisposing gene to a woman where the family diagnosis was Lynch syndrome. And what it does is explain why one of the things that we bang on about in genetics is we need information about the family, and we need accurate information about the family, because we can't make diagnoses without that. We can't give you risk estimations about information about the family unless we have some clear information. And this was the way of diagnosing Lynch syndrome. So you would use something called the modified Amsterdam criteria, and as you can see, this is actually quite complicated. You needed to have a big family. You needed to have a number of cases of cancer which related to Lynch syndrome. And what you'll see is a very old slide, so it calls it HNPCC. And they needed to be across 2 generations. So actually, you needed to have a significant family history in order to actually get a diagnosis of Lynch syndrome. Lynch syndrome is caused by pathogenic variants, variously called mutations or faults, in these 4 genes, so the mismatch repair genes, MLH1, MSH2, MSH6, and PMS2. And these genes all work in a process which is in the normal physiological process within the body, which is repairing mistakes in DNA. So every time a cell replicates, you will get mistakes in DNA, and there are a number of systems in the body to repair those. And the proteins that are produced by these genes are sitting within that replication and that process for repairing cells. So if you get a fault in any one of those genes and that protein is missing, then that process doesn't happen. And if you get an accumulation of errors within a cell, then you'll get abnormal growth, and that's why you are predisposed to developing tumours and cancers. And so this pathway here, where you get a lot of repeats, is also where you then get something called microsatellite instability if it doesn't work, and that's what you'll see as part of some of the diagnostic tests for Lynch. We all know that Lynch syndrome causes an increased risk of malignancy, and this is data from an international collaborative group which collects data from a number of places around the world, including the UK, and there's a number of groups in the UK that contribute data. And this gives us information about cancers that have been identified in individuals over time. So it's called the Prospective Lynch Syndrome Database because we've been looking at people who've been diagnosed because of definite gene faults and seeing what happens to them over time. What you will see is in the brackets, we've got the range. And so when you get to something like PMS2, the range of risks is really huge. So I think it's really quite important to remember that whilst we can give you risks associated with a gene change, they are not 100% accurate. We know that these are estimations based on the data we have, but those data will change. And there's just been a more recent call for data for the PLSD, so there'll be some more data added to this that hopefully we'll get information through in the next sort of 12 to 18 months to give us a more accurate range. But it is really important to realise that what we're giving people is ranges of risks rather than, this is not written in stone. And from this, you can see that the high risks really are colorectal and endometrium, but then you've got an increased risk of some of the urological malignancies. There's also risks of other things. So I know we've got a talk this afternoon from the dermatologist about the sebaceous carcinomas one can see with a condition called Muir-Torre syndrome, which is a variant of Lynch syndrome. So there's an increased risk of colorectal cancers and endometrial, and as I say, the risk of ovarian cancer, you often see mucinous, you often see endometrioid, so very specific pathology under the microscope. And that all gives us an idea of what we're looking at. And again, there's very specific cancers in the urological tract. In terms of screening, we concentrate currently on colorectal and endometrial. Ovarian screening, the risks are not that high compared to other syndromes that I see. And ovarian screening has so far proven to be fairly fruitless. We can't do that. And I know that there'll be talks later on about screening for and testing for the urological malignancies that one can see. So you can diagnose via family history, as I've said. I regularly see patients who come into the clinic saying that I've got this family history of cancer. We'll do the investigations. We'll work out that it's likely to be Lynch. We'll then go on and do testing of an individual if we can. But we know that this is really inefficient, and actually there are families that were being missed if we were relying on this way of ascertaining. And that's, excuse me, why the NICE guidelines were drawn up. So I was, along with other members of this audience, on both of these committees, looking at the recommendations for ensuring that you get testing of tumours. So it's well recognised that you can do a testing of a tumour, which will then give you some information about the likelihood of that tumour being in an individual who has Lynch syndrome. It's not a diagnostic test. So saying you've found an abnormality on immunohistochemistry or microsatellite instability in a tumour doesn't mean that individual has got Lynch syndrome, but it means that individual needs further investigation. But this was, these guidelines were published in 2017 and 2020. And the problem with NICE guidelines is that they are guidelines, they're recommendations, and there's no funding. And so it became quickly very apparent that whilst this was being suggested to happen, it wasn't necessarily happening. And that's then led on to all the work that Adam's going to talk to you about in terms of trying to get this up and running nationally to improve the diagnoses of Lynch syndrome. So we now have reflex testing of colorectal cancers and endometrial cancers. If you look at the 2019 data, certainly in the Northwest, we were only probably testing about 30% of tumours. Now that's gone up considerably to about 90%. So there's been a lot of work in this area, and we are now at the stage where we are diagnosing or identifying individuals who might be at risk of Lynch syndrome and then doing further investigations. And there's now work looking at whether one should do IHC or MSI of other tumours. And the other driver behind this isn't just about diagnosing Lynch syndrome, but actually concurrently there were some advances around therapy for bowel cancer with a particular drug which works very well if you have IHC or a microsatellite instability. So that was another driver to try and making sure that all these tumours were being tested. The other thing we are seeing more and more now, which is becoming more challenging, is what we would call an incidental finding. So there are lots of individuals who are having genetic tests for a variety of problems. And a way of testing that is to do something called a whole genome sequence, which is to basically look at large panels of gene across an individual's genome. There are a list of recommended genes in which we know that if you find a gene change, you can then do something about it. And there's this list that's been produced so that irrespective of the disease that's being tested for, if you identify a fault in one of those genes, you need to let the patient know. The Lynch syndrome genes are on that list, which means that we are now seeing patients who have been seen in the genetic service for a neurological condition or a metabolic condition or as a child with learning disability where they're identifying faults within the Lynch syndrome genes. That's a particular challenge because often these are young people. Often these people have no family history at all, and so are not aware of any cancers in their family, let alone the fact that they might be at risk. And then trying to explain to these individuals that they may well be at risk, but all our data about Lynch syndrome are, in the main, about families who've had a cancer and then we've identified another individual. We're not terribly sure what the risks are in people who've got absolutely no family history. So that is becoming more of a challenge, but clearly these patients will need to go into the screening programme until we can work out exactly what their risk is and when if it's ever going to be safe to say, well, we don't need to worry too much. So Lynch syndrome, as you know, everybody needs colonoscopies every 2 years. Depending on when you were diagnosed, you may well have been told it was 18 months to 2 years, and some of that 18 months was very deliberate on the part of genetic services and gastroenterologists, because we know that the screening system would slip. So we were saying 18 months to 2 years in the hope that actually everybody got their screening at the 2-year point. We know that that was inefficient. And that's been one of the drivers around trying to get patients with Lynch syndrome into the National Bowel Screening Programme. And I know that we're going to have more talks about that later today. Kevin and I are particularly delighted, having spent a large number of our years and a lot of our time sitting on various committees, that actually patients with Lynch syndrome were entered into the National Bowel Screening from July 2023. And certainly I've seen a few patients of mine now who are happy with the way that system will work. So the screening, if you've got MLH1 or MSH2, is from 25, if it's MSH6 or PMS2 from 35, and that's based on the data we have about the cancer risks and the age of onset. There are some families where there are exceptions. The ages are different in terms of the age at which the first cancer has happened, and in those families we do have the flexibility to start screening at a different age. When you're looking at endometrial cancers, and again we'll hear more about this, the evidence around screening for endometrial cancers is limited. The data are limited. Currently, the recommendations are you can offer screening, and certainly within the Northwest, we would offer hysteroscopy and Pipelle biopsy, and then discuss risk-reducing hysterectomy and BSO from around the age of 35. But again, I say the evidence around all of that is difficult and limited, and there are a lot of studies trying to look at this. The other thing that we do have evidence for, however, is H. pylori testing and the use of aspirin. So historically, there was some evidence that Lynch syndrome caused an increased risk of cancer of the stomach, but that appears to be related to an H. pylori infection. So one of the pieces of advice that anyone at a point of new diagnosis should have is to go and get your H. pylori tested. It's an infection in the stomach. If you have it, then you take antibiotics, pretty unpleasant antibiotics, but antibiotics for a couple of weeks, and then it goes away. And that reduces the risk of stomach cancer in patients who have Lynch syndrome. And then there's very good data about aspirin. We're not sure about which dose to go on as yet, because we're still waiting for the results of the CAP3 study. But they're advised that patients should go on aspirin, certainly if they're under 65. I've talked about the National Bowel Screening Programme. The advantage of this is that it's actually a robust recall system. We know that people will get called for their colonoscopies at the appropriate time, and we know that everybody who is involved, or the endoscopists involved in the National Bowel Screening Programme, have had appropriate training, and it's high quality endoscopy. And as I say, Kevin will talk about that a bit later. Just to run through the inheritance, and again, I'm sure many of you know about this, Lynch syndrome is inherited in an autosomal dominant fashion, and that means that if you have Lynch syndrome, then your children will have a 1 in 2 or 50% chance. It doesn't mean that if you've got 4 children, 2 of them will have Lynch syndrome. It means that for each child, there is a 1 in 2 chance, and it's like tossing a coin. So you may be really lucky, and none of your children have inherited it, or you may be unlucky and they all have. It's all just random. But because if we can identify an individual who has a pathogenic variant in one of those genes, we can then offer testing to family members. We call that predictive testing, because we're predicting whether someone's going to be at increased and whether they need to go into the screening programme. We would offer it from adulthood, so from the age of 18, when someone is able to consent. You often find that young individuals will leave testing until they're around the age at which screening would start, because sometimes it can be really quite hard knowing you're at risk of something and no one's doing anything about it. So we will talk to individuals about that when we see them. We'll talk to them about whether they want to know about it now, how much they think it will reduce their anxiety. A lot of people come in saying, well, I just want the test to prove I'm going to be all right. Well, actually, it might not. So you need to think carefully about whether you want to know whether you've got an increased risk of cancer, whether you think you can cope with the screening. And the other thing we do is think about the timing of the test. Often it's a bit of a no-brainer. Yeah, there's a test, I'll have it. But actually, what's happening in your life? Are you at university? Are you thinking about planning a family? Are you just about to get married? Have you got a relative who's actually terminally ill? All of these things need to be taken into account when you're considering having a test that might be difficult to hear the results. So I think we do a lot of discussion with individuals before they think about predictive testing. And we usually, once someone is seen, we will then talk to them if they're positive about what the plans are. I think the other thing we often talk to people about is if they have a test, what the impacts are on other members of the family. If you have children and you are shown to have the variant, then that means the children are at risk. How do you feel about that? What have you told the children? How old are them? At what point do you start talking to them about it? If it shows you've inherited that variant from one of your parents, how are they going to feel about it? Have you spoken to them about it? If you're in a big sib ship, so you've got lots of brothers and sisters, and you're all thinking about having testing at the same time, well, what are you going to do if you get different results? If you're really close, how difficult is that to manage? If you're okay, but one of your sisters isn't, is that going to impact on the family? So it's actually quite a lot of thought process and quite a lot of discussion before people have a test. But then once you have a test, if you're shown to have Lynch syndrome, you go into the system. And we now have a system for registering patients to make sure they get into the National Bowel Screening Programme. So in theory, everybody should be ascertained who's got a fault in one of these genes and then taken down the surveillance route. I think the other thing I just wanted to say really is that there are a series of regional genetic services in the UK. There's 20 services across the whole of the UK. You, if you've been diagnosed with Lynch syndrome, will have gone through one of those services at some point. And I think if you have any questions about Lynch syndrome, you need to go back to your genetics service. So if you have questions at the point of diagnosis that you're not sure what that meant, go back to your genetics service. If you're thinking about having family and you want to ask about what your options are or go over the inheritance again, go back to your genetics service. You know, this is something that you've been diagnosed with that will impact upon you for the rest of your life, but there is a service out there which are offering lifelong care. And if you've got concerns, you need to go back to that service. You can find, you know, if you're moving around the country and you're not sure where you go to, there's a website for the British Society of Genomic Medicine, so BSGM, and they list all the services on their website. So that's all I was going to say.
Hi. A few years ago, at a similar forum to this, a question was asked, could Lynch jump a generation? And the emphatic answer was no, it doesn't miss. In light of the fact that you've now been talking about somebody with no trace in the family, is it possible that maybe there's another variant, or it maybe does skip generations?
So it looks as though the disease skips generations, but the gene doesn't.
Okay.
So if you have a variant in a gene, you've got something called penetrant, so which is how likely that gene fault will cause a growth or a cancer. And that varies. So with PMS2, for example, the cancer risks are really quite low. If you've got a variant in PMS2, the estimated bowel cancer risk is about 20%. Well, that means 80% of people who carry that gene change won't develop a cancer.
Right.
So look at a family, it'll look like everybody's okay, even if you've got that inheritance running through the family. So the actual gene change doesn't skip, but the disease looks like it might be.
Thank you.
My daughter actually has a microdeletion of chromosome 2, so she's one of those actually have Lynch syndrome as such. I'm just wondering, her geneticist says she's the only one that she's seen. So of course there isn't no really history. I'm just wondering, like, how have you seen many?
So I think we've got one individual with Lynch syndrome. We've got lots of individuals with microdeletions who've picked out other cancer predisposing genes. So we see an awful lot of them, and I think it's really difficult. I think it's really difficult at the point of diagnosis because obviously the microarrays for another reason. And I think also it's quite hard to talk to someone who's got a child where actually that's probably not going to impact for the next 20 years.
Yeah.
So I think it's a real challenge for us, and I think it's a real challenge for families for this to come out of the blue.
Yeah, I mean, we were told when she was 3 that for the unique website, they said that obviously, like, there is a predisposition of bowel cancer, but it was never kind of like, but that was obviously like 15 years ago. So now it's like, oh, they're both, the 2 and the 6 are missing completely. So like, we're going to class you as Lynch. So she has started a 16 screening, which is brilliant. But it's just I think it's just getting around the head of how many there are.
So I think it's often, you'll see people who've got that sort of general genetic mechanism, but finding someone who's got the exact change is often very challenging, and a lot of these are unique and rare.
Yeah.
And so actually being able to predict is very difficult.
Yeah.
And I think hopefully with the new Lynch syndrome register, we'll be identifying people who've got different ways of ascertaining. So we may get information long term, but it's going to be long term, and it's often going to be difficult to say it definitely applies to an individual.
Yeah, no, just the way they word it is if like, oh, she's got Lynch syndrome, but she hasn't kind of. But no, that's okay. I just wondered if like you had other, like other children with or adults, because obviously she's 18, going to be 18 soon, that if got both missing and.
I don't think we have in Manchester. Certainly, I haven't seen it. I don't know if Adam has in.
Yeah.
Where's his?
Okay.
No.
Going back to the first question, I've got MSH6, which was diagnosed 6 years ago, and I've had bowel cancer and endometrial cancer, both at the same time, really. Does that mean I could be more likely to get bladder? Should I be asking my doctors for, some bladder checks, cystoscopies, sort of every couple of years?
So I think we're going to get a talk about screening.
Yeah.
John's nodding at me.
Yeah.
I don't think there's much evidence for that sort of screening at present.
No.
I think the MSH6 doesn't necessarily mean you having had 2 primaries doesn't
mean
you're
no.
necessarily going to get another risk.
Yeah, I have had another one. I've had breast cancer as well, but yeah. And the other thing, going back to the first question, my son has got the gene, and my 2 daughters didn't have it. So you said that the gene might not necessarily be passed on, but the disease can be. Could you explain that more?
So if you've got an MSH6 variant, each child has a 1 in 2 chance of inheriting it. And that's, if someone's got the gene change, it doesn't mean that you automatically have the disease. So you can have the gene change and not go on to develop a cancer.
No.
But if you've got the gene change, you can then pass it on to children.
Yeah. So my 2 daughters...
If they haven't got the gene, that test's 100%. They run it. They run the test. They look for that specific change that you've got. They will run it with your sample as a control, so they know they can pick up that change. So it's 100%. If they haven't got it, they haven't got it.
No.
And they therefore can't pass that on.
Or their children. Yeah. Okay. Thanks.
Yeah. A quick comment about the microdeletions. They often don't just affect the Lynch genes. Those are sort of alsos, because there'll be probably some learning difficulty associated genes in that big piece of chromosome, and there could be 5, 10, 20, 50 genes missing, and so you can get some really unusual effects. I've seen it in another patient who was prone to a particular sort of rare polyp predisposing to cancer. He'd lost the whole of the end of that chromosome, so he'd lost this gene and 50 others. He had absolutely no signs of the condition that predisposes to bowel cancer. None at all. He had half a dozen other things, major things, but not that one. So there may be other genes nearby that influence it. And just to touch on the issue of breast cancer in Lynch, there's been a recent study in the Netherlands looking at breast cancer in Lynch patients, and there is no more breast cancer than you would expect by chance. But the type of breast cancer is subtly influenced by having Lynch syndrome. So it changes its spots to a rarer sort, a bit like the ovarian cancers, and not the associated with BRCA1 and 2. They're different animals. And we've been looking in UK Biobank across 500,000 people. We've found just over 1,000 people who have a Lynch mutation, and we've looked at the rate of bowel, endometrial, and breast cancer. The rate of bowel and endometrial is exactly as you would predict from the prospective database, the numbers that Fiona put up. The rate of breast cancer is precisely as you would expect from the general population. So there is absolutely no increased risk overall, although the type that might turn up is influenced by having Lynch. So it's a very interesting thing. Yeah.
Hi, yes, morning, Fiona. You mentioned that tumours can be diagnosed to help pick up the existence of Lynch. I was wondering if tumours can be diagnosed to identify whether they are Lynch tumours, if that's a slightly different thing. This is in the context of my mother having TCC, urethra cancer recently. We know she carries a Lynch gene, but I'm wondering, could that just be an incidental cancer that isn't related, in which case I don't need to look out for it selfishly? Do I understand the question?
So I think if it's a TCC and it's urethral, it's probably going to be associated with Lynch, but you can do tumour investigation to try and confirm that, yeah.
Right.
But
So
we know there is a definite association with TCC, urethral TCCs and Lynch syndrome.
So the assumption is that it will be a Lynch cancer, and it's not just going to be a...
I mean, I think if you've got
Right.
slightly more unusual tumours, it's often worth trying to investigate further. But with something that's clearly has been recognised before, I think we would make that assumption, yeah.
Okay, thank you.